In our previous lecture, we examined how communication abilities change with normal and pathological aging. We explored sensory changes, processing differences, and how conditions like dementia can affect expression and comprehension. In this lecture, we shift from understanding communication change to enhancing communication practice. Effective interaction goes beyond clarity and emphasizes dignity, empathy, autonomy, and trust. Effective interaction is about recognizing older adults as full participants in their care and in their communities. Whether we are interacting in a hospital room, a long-term care facility, a primary care office, a community center, or someone's home, the quality of our communication shapes elder outcomes. Small adjustments in our communication practices can make an enormous difference in care. Let's begin with foundational principles as it relates to communicating with older adults. On respect and personhood. Always address the older adult directly, even when family members are present. Avoid speaking about them in the third person when they are capable of participating. Use their chosen name and pronouns. Ask how they would like to be addressed. Avoid infantilizing language. Terms like sweetie or dear or exaggerated sing-song tones, sometimes called elder speak, can feel patronizing and undermine dignity. Using respectful language is ethical and demonstrates compassion and care. On clarity, speak at a moderate pace. Don't rush, but also avoid exaggerated slowness that suggests assumed cognitive decline. Use plain language when discussing medical topics. Replace jargon with understandable explanations. For example, instead of, "You have congestive heart failure," consider, "Your heart is not pumping as strongly as it used to, and that can cause fluid buildup." Clarity enhances autonomy. On enhancing the environment, we must remember that communication can be impacted by our surroundings. Reduce background noise when possible. Turn off televisions and close doors. Face the individual when speaking. Ensure adequate lighting so facial expressions and lip movements are visible. Sit at eye level. Avoid standing over someone, particularly when discussing important topics. These environmental changes often matter more than changes in speech volume. Finally, on understanding, do not assume comprehension. Use the teach-back method, where you ask somebody to repeat instructions or information back to you. As an example, you can say, "Just so I know I explain this clearly, can you tell me how you'll take this medication?" Ask open-ended questions rather than yes or no questions. Encourage questions by normalizing them. You can say something like, "Many people have questions about this. What would you like to ask?" Let's now focus specifically on clinical environments, starting with a discussion on shared decision-making. In clinical care, communication must align with what matters most to the patient. Incorporate the "what matters" principle. What are your goals for your health right now? What concerns you most about this treatment? Shared decision-making respects autonomy and avoids paternalism. Older adults may prioritize independence, pain control, staying at home, or minimizing medication burden. These priorities may shift due to a variety of factors, and only through clear communication can we ensure any prescribed treatment aligns with their values. Let's now address chronic disease management. Many older adults manage multiple chronic conditions. Avoid overwhelming them with excessive information at once. Break discussions into manageable segments. Prioritize function and quality of life over isolated disease metrics. For example, rather than focusing solely on blood pressure numbers, discuss how treatment affects mobility or daily comfort. In communication, we also have to account for emotional validation. Illness often carries emotional weight: fear, frustration, grief. Reflective listening can be powerful. "It sounds like this diagnosis feels overwhelming. I can see that this has been frustrating." Validation does not require agreement, it requires acknowledgement. Research consistently shows that emotional attunement improves trust and adherence. And finally, let's spend a moment on addressing sensory impairment. Before assuming cognitive difficulty, assess sensory barriers. Ask, do you have your hearing aids today? Would it help if I wrote this down? Face the patient. Avoid speaking while typing into a computer. These small adjustments prevent misinterpretation of sensory challenges as cognitive decline. Communication outside clinical environments is equally important, and while some skills and best practices carry over between these settings, there are some considerations that are unique to each. Let's first begin with a sentence or two on community and home settings. In community centers or homes, avoid rushing conversations. Allow pauses. If you're having a conversation with an older adult and they are quiet, remember that silence is not necessarily a failure in communication. It may reflect processing time. Engage in reciprocal conversation rather than interrogative questioning. Ask about experiences, memories, and preferences. Meaningful engagement supports emotional well-being. Now, on loneliness and social isolation. In non-clinical contexts, conversation itself may serve as intervention for an older adult who is isolated or lonely. But first, we have to remember that there is a difference between these concepts. Those who are socially isolated have a limited network size, while those who are lonely experience a subjective feeling of disconnection. If you identify an older adult at risk for isolation or loneliness, simply acknowledging connection can help build rapport and give vital information on how to help them. Asking things like, who do you enjoy spending time with? Or are there activities you miss? Can provide insight on pathways to support. One final note about non-clinical communication centers on cultural sensitivity in everyday interactions. Respect cultural norms regarding eye contact, family hierarchy, and decision-making roles. Do not assume independence is universally valued. Ask questions rather than assume anything, like, would you like to include your daughter in this conversation? Or, how do decisions like this usually happen in your family? Cultural humility enhances relational trust. Communication accommodation theory explains how people adjust speech in response to perceived ability. Appropriate accommodation, such as speaking slightly more slowly in response to hearing loss, can enhance clarity. Over accommodation, such as exaggerated simplification or patronizing tone, can undermine dignity. Research suggests that elderspeak may increase resistance and reduce self-esteem. The key question is, are you adjusting based on observed need or on stereotype? Effective communication also requires emotional intelligence. In this way, we must be mindful of attunement, conflict management strategies, and best practices in supporting autonomy. On attunement, notice nonverbal cues, posture, facial expression, tone. An older adult may hesitate before responding. Allow space. On conflict management, in emotionally charged situations, lower your voice rather than raising it. Use calm, grounded language. Avoid arguing facts in the heat of emotion. And on supporting autonomy, give time for decisions. Avoid finishing sentences unless requested. Allow agency whenever possible. Communication does not occur only between individual provider and patient. It is shaped by teams and systems. Ensure consistent messaging across team members. Provide written summaries when appropriate. Train staff in age-friendly communication practices. Organizational policy should reflect respect for older adults, from signage to scheduling practices. For healthcare professionals and those training to become professionals, this means recognizing that communication culture is a systems issue, not only an interpersonal skill. This lecture connects directly to earlier modules. From Module 1, we discussed ageism. Communication can either reinforce or reduce ageist assumptions. From Module 3, we examined cognitive changes. Slower processing does not equal incompetence. From Module 4, we explored social context. Cultural norms shape conversational expectations. From Module 5, we emphasized cultural humility. No interaction is culturally neutral. Effective communication embodies ethical, psychological, sociocultural, and structural awareness. To summarize, enhancing interactions with older adults requires respectful language, clear communication, environmental adjustments, emotional attunement, cultural humility, and system-level awareness. Small communication shifts can significantly improve quality of life, care outcomes, and trust. As you reflect on today's lecture, consider: what subtle communication habits might unintentionally undermine dignity? And how can you adjust them? This concludes the second lecture for Module 6. If you have any questions about the material covered in this lecture, please contact your instructor for this course. Thanks for watching.